Good morning, good afternoon, good evening, everybody. Thank you very much for joining this webinar today. The webinar is about personalized medicine and why it is so important in fighting cancer. My name is Walter Ricciardi. I'm professor of public health at the Catholic University in Rome and president of the Mission Board for Cancer of the European Commission. And today we are going to discuss about the work carried out by the IC2PERMED in collaboration between Europe and China. Why is important, personalized medicine, and why is important to think about this for cancer. Cancer is a major threat. In the burden of disease in both countries is increasing. Just to give you an idea, Europe with less than 10% of the world population has already 25% of the burden of disease. And if we don't act now strongly and immediately, this burden will increase substantially in the next 20 years, leading Europe to lead this unfortunate figure in a way that could reach unimaginable burden of disease. And the same is China is increasing, and certainly this is a problem for such a big country with such a big population. So it's important to fight that at population level. And the European Union and European Commission is doing that seriously, essentially with two programs. One related to DG Research, which is the mission board, the mission cancer, which I have the honor to chair. And this is essentially the first time that the European Union is approaching the project and the problem as a mission. So as an ambitious target to be reached in the next 7 years, saving 3 million lives, and improving prevention, diagnosis, and treatment quality of life, with a particular attention to bridging the gap of inequalities between different regions of Europe, but also within the countries. And this program is very well connected to the European Beating Cancer Plan, which is managed by DG Santé, which is a vast program in order to tackle practically and to give member states the possibility to tackle cancer in a very serious way. So this is very much at population level. There are 13 bold actions that are going to be implemented, and they have already started to be implemented with a series of call and actions, both for the missions and for the European Beating Cancer Plan. But this is very important to be pursued in the same time at personal level, with a personalized approach, because cancer is not a single disease, it's a series of diseases, and every single person, every single individual has a different way to react to different treatment, as a different kind of disease, which can be imagined as matched only with a personalized approach. And this is the work that we are doing in Europe and in China. And we are going to talk today with two champions of this program. The IC2PERMED within Europe and China is a major program that essentially aims to provide policymakers in both parts of the world, so both in Europe and in China, with key solutions for enabling the convergence of a common approach of personalized medicine under this international consortium for the benefits of citizens, of course, in Europe and China, but after all over the world. The project in which European and Chinese partners are dedicating efforts for what? For mapping policies, programs, standards, and initiatives related to personalized medicine in Europe and China, for identifying the opportunities for research collaboration, structuring developments of an ecosystem of European and Chinese experts collaborating in working groups centered on IC2PERMED actions plan priorities, and then exemplifying research collaboration frameworks between China and Europe for personalized medicine by connected biobanking, and setting bridges with key official organisms involved in the definition and implementation of personalized medicine and healthcare systems in both economic areas in international context through IC2PERMED, as well as relevant initiatives and networks. As I said, we have today two major champions of the program, Professor Stefania Boccia and Professor Shuhang Wang. Professor Stefania Boccia is a full professor of hygiene, preventive medicine, and public health at Università Cattolica del Sacro Cuore, and she is responsible for the research line on healthcare, sustainability, and personalized medicine at the IRCS Fondazione Policlinico Gemelli in Rome. She is the director of the section of hygiene of the Department of Health Science and Public Health of the Catholic University and president of the Public Health Epidemiology section of European Public Health Association. Her main research interests concern personalized medicine policy in Italy and internationally, and the interaction between genetic and environmental factors in the risk and prognosis of gastric and head and neck cancer. Professor Shuhang Wang is a PhD graduate from Peking University. She is the clinical director of the GCP Center, the Cancer Hospital Chinese Academy of Medical Science. She is also the executive director of the Clinical Oncology Diagnosis and Treatment branch of the Fujian Straight Medicine and Health Exchange Association. She's a member of several committees, such as the Clinical Research Professional Committee of Beijing Cancer Society and youth member of the Professional Committee of Tumor Markers of China Anti-Cancer Association. She has published extensively and the first authors in journals such as Journal of Thoracic Oncology, the Journal of Genetics and Genomics, and Frontier in Oncology. So without hesitation, I'm going to ask some questions to both of them, taking advantage. I hope that they are all connected and ready to answer the question. If I may, I will start from Professor Boccia, because I see that Professor Wang has been timely disconnected. So Professor Boccia, can you highlight the main achievements in cancer personalized medicine in your country? What is the plan for the future?
Thank you very much, Professor Ricciardi, and thanks to the World Federation for organizing this workshop within the IC2 PREVENT project. So as you've been mentioning, genomics plays an emerging role in clinical and public health research, and we know that cancer is strongly driven by genomic modification, so that the wide profiling of this modification with all the new technological approaches has become a major asset for early diagnosis, for prognosis, and for therapy in regard to personalized medicine. The field of oncology, therefore, is undergoing a real process of structural and organizational change due to the introduction of this genomic-based tool and for many types of cancer. This is a cultural change, I have to say, that marks an era with significant effects on the health of the patients and also of the organization of the healthcare systems. And the application of such approach while guaranteeing a sustainable and high standard of performance should be accessible to all cancer patients across Europe and the world. And will be in the short term also a key objective of a number of European funded projects that really aim to upscale available innovation and also available national initiatives. By answering more precisely, however, your question related to the main achievements of cancer personalized medicine at the European level, I want to distinguish between those available for prevention and diagnosis of cancer and those available for therapy. So concerning diagnosis and prevention, there is a number of genetic tests available since more than a decade to detect some germline mutation in blood that are related to hereditary cancer or to syndromic condition that overall explain around 5 to 10% of the burden of disease for cancer that predispose to the development of cancer itself. And many of these mutations can be identified to specific genetic tests performed in the blood, as I say, which are already guaranteed for free in the large majority of European countries since more than a decade. Some of them are breast cancer associated genes 1 and 2 for hereditary ovarian and breast cancer, APC for familial adenomatous polyposis, mismatch repair genes for Lynch syndrome, which is an hereditary form of colorectal and endometrial cancer, and many others. And the research of these genes is performed in the blood of individuals who already have the disease and may develop also secondary cancer, and also to screen family members, relatives with established disease who may be carriers of such pathogenetic variant but not affected yet by any neoplastic disease. And the search for this germline mutation to assess the increased familial risk is a path that is established through the oncological genetic counseling. In these subjects who therefore have a higher risk of developing this neoplasm, there are screening and surveillance programs already in place at the European level that aim at monitoring these subjects in order to prevent and make early diagnosis according to international guidelines that also make a difference according to age groups. While concerning not diagnosis and prevention, but personalized cancer therapy, More recently, there are a number of genetic tests performed on tumor tissue, so in order to detect not germline, but somatic gene mutation that can be useful to establish prognosis and also target therapy. And many of these tests are already reimbursed by the healthcare system. Some are KRAS, NRAS, BRAF in patients with metastatic colorectal cancer, or EGFR, KRAS, and others in patients with advanced non-small cell lung cancer that can be treated with the EGFR inhibitors, and also BRAF in patients with metastatic malignant melanoma that can be treated with BRAF inhibitors, and others for follicular cell thyroid cancer. So there is a focus at the EU level, but of course internationally, on developing and updating guidelines for the appropriate use of such genetic tests in order to guide patient treatment, supported always by clear evidence-based guidelines. I have to say that at European level, and then I hand over to my colleagues from China, that there are a number of already available programs in place, like in Belgium. There is an introduction of next generation sequencing, the plan to introduce it routinely in oncological care. The same in France, the same in Germany. Also in Italy, we have the Alleanze contro il Cancro, so a network of cancer centers that rely on scientists and a working group that aims to foster the use of such genetic and genomic application into cancer prevention and treatment. The same we have in Netherlands and also in Portugal. So we have a number of strategies ongoing at national level, and that will be also harmonized at European level in order to upscale this innovative approach in cancer diagnosis and care.
Thank you very much, Professor Boccia. Professor Wang, if you are with us, I have already introduced you as a major player in China. Can you highlight the main achievements in cancer personalized medicine in China, and what is the plan for the future in your country, please?
Okay, thank you. I think just like Stephanie said, in China, I think non-small cell lung cancer and melanoma patients are the benefit from the personalized medicine most, because I am a specialist in lung cancer area. Actually, I have studied lung cancer from 2006, yeah, when I was a postgraduate student. From that time on, we are using the EGFR mutation testing to give patients the personalized medicine like gefitinib or Tarceva, or now we have ositinib and many other drugs. So I think non-small cell lung cancer patients benefit from the personalized medicine the most. Because in Asian patients we have EGFR mutation, the high rate of EGFR mutation rate, like in adenocarcinoma women, non-smoking patients, the rate was almost 60%. Yeah. So many patients benefit from EGFR TKI. This is the first step. In non-small cell lung cancer, I think it builds a very good model for cancer research and cancer drug development in China. And then we are learning a lot of things from the resistance mechanism exploration of this cancer. So including the c-MET amplification, including the KRAS mutation, and many other gene alterations in the same pathway. So we have following the steps from the world, especially United States and Europe. Yeah, we got a lot of new drugs now for the anti-resistance of EGFR TKI treatments, like amivantamab. It's already got the indication in China now, with this, like patients with c-MET amplification. Yeah, maybe soon the exon 20 insertion. Both of those are the main resistance mechanism alterations in non-small cell lung cancer patients. So I think now in China, I think it is the same with the world. The 5-year survival rate of non-small cell lung cancer, the advanced stage non-small cell lung cancer, they have a 5-year survival rate at almost 30%, right? For the EGFR mutant non-small cell lung cancer. Yeah, of course, because the PD-1 inhibitor is faster developed worldwide, like we have a lot of PD-1, PD-L1, maybe it's more than 10 types of different PD-1 and PD-L1. Yeah, it is the same in Europe, right? But it's not very same in United States. United States, they only have Pembro and like nivolumab as PD-1 inhibitor, but in China, we have more than 10 types, different types of PD-1. It decreased the cost of the medicine, and also it make more people are available to use these kind of drugs. So patients with PD-1, PD-L1 positive, it's kind of a personalized medicine too, right? People with PD-L1 positive expression, so they can have a longer survival rate as 30% too. So I think the non-small cell lung cancer patients, no matter using the TKIs or the PD-1 inhibitors, they benefit from the personalized medicine the most. The other type of cancer, I think, is melanoma, because I'm not a specialist in melanoma, but I know that in Beijing Cancer Hospital, I worked in Beijing Cancer Hospital 5 years ago. There is a very famous melanoma specialist in that hospital. It's Dr. Jun Guo. I think most people have heard of him. I know his team did a lot of work in melanoma. So including the BRAF mutation, the KRAS mutation, and KIT mutation. And so they have a lot of clinical trials, very, very good clinical trials in their department. So they published very good papers, and they are very famous and have a very high reputation in this area. Because, you know, melanoma is not cancer with high insistence in China. It mostly happened in, Western countries. But we have a very famous center here in Beijing Cancer Hospital. So they accumulate all the patients here. They have done a lot of very good clinical trials. So they give all the melanoma patients around China a very good option to treat. So I think melanoma is another cancer.
I think we have problem with the connection with Beijing. Yeah, essentially, Professor Wang, we can't hear you very well. We wait for you to solve the problems. And just a comment about melanoma in Europe, we still have a problem of wide inequalities in the care of this disease. Just to give you an idea, in the board, we had the president of the Melanoma Patients Associations, and she just told us that concerning melanoma patients in the east of Europe, they essentially do not have access to the drugs that we have mentioned. So the first possible countries where patients from Eastern Europe can be treated is Poland, and so essentially she is managing to facilitate the access of the Eastern countries, not to mention, of course, now the situation of the war. But just to give you an idea concerning melanoma, there is a problem in Europe of inequity of access to best care. So what we were hearing from China, that essentially is coordinating an excellent point of care to treat patients, even in this incredible wide country, is very interesting. Hoping that Professor Wang can reconnect, I go back to Professor Boccia. Professor Boccia, what are the main obstacles you have faced and the best levers you have used to implement personalized medicine, of course, in Europe and in Italy?
Well, this is not an easy question in terms of elements to summarize in a few minutes. Anyway, I'll try to do my best. Basically, I'm a public health professional, okay, so I'm not a clinician, and I participated also with Professor Ricciardi in the movement of public health genomics since its inception in 2005. That just like precision medicine, the aim of precision public health, because now the terms has evolved more to precision public health, is to provide the right intervention to the right population at the right time, with the goal of improving health for all. So applying genomic tools in the clinical practice in oncology requires, by definition, a multidisciplinary research collaboration that includes a number of professionals, not only oncologists, but public health professionals, experts in healthcare organization, and of course, also patient advocates and oncologists and many, many other professionals. And in this sense, today, a central element of the new oncological governance is represented by the so-called molecular tumor board that are in the hospital embedded as a multidisciplinary teams made by oncologists, geneticists, bioinformaticians, hematologists, pathologists, and also a nurse and many others like pharmacologists that have the main task of interpreting the genomic profile of a tumor, so combining the germline mutation information and the somatic mutation alteration, and then recommend the best therapy for the patient. So this is really one of the cornerstones, also the discussion around the comprehensive cancer center, because these are at the top of the agenda of the European Cancer Mission program and funding. So embedded in the comprehensive cancer center across Europe that should adopt the same standard of care, a relevant role as the molecular tumor board. They should guide the treatment based really on the patient experience and on a personalized information and a guidance, therefore. I also participated personally in the joint action IPAC, which stands for the Innovative Partnership for Action Against the Cancer, that has been funded from the European Commission and finished just a few months ago. And in the joint action IPAC, the objective was to implement innovative approach to cancer control and to release a roadmap for the implementation and sustainability of cancer control. In this joint action, there was a work package led by Shenzano in Belgium that was dedicated to genomics in cancer care. And we mapped and identified the core competence for cancer genomic education, because I believe that this is certainly one of the best levers to implement personalized medicine. The fact that physicians and health professionals overall are very much aware of this revolution, can properly interpret it, and can properly guide within or outside the multidisciplinary board, but also at policymaker level. And in fact, we developed within the joint action IPAC a distance learning training platform that has been developed from the Italian group of the National Institute of Health to give for free a medical education platform in cancer genomics. This was actually the first one developed ever. And in fact, now there is also a call made by the DG Health, closed a couple of months ago, that Shenzano actually prepared in order to reply to this call. And in this proposal, an important part will be on cancer education, cancer genomic education, because we aim to upscale this platform already developed and released in English in local language across Europe, because of course, even in Italy, we know that this kind of education made in English cannot really be that much, have a great impact. Other points very quickly in order to answer concerning the best level to implement cancer genomic at the European level and Italian level, health technology assessment. So for fostering the uptake of this innovation, we need a continuous HTA approach, where economic evaluation certainly has a very important value. As long as I know, ICPermed, so not IC2Permed, but ICPermed, so International Consortium of Personalized Medicine, funded another CSA a few years ago, which is just addressing this aspect. So understanding and delivering the best HTA model to be used for personalized medicine, and also in the context, of course, of cancer. Another very important aspect I want to mention is creating awareness within citizen. I will probably approach this topic maybe later in the discussion. And this is central at the European level, also in terms of funding support of the mission cancer. While another aspect strictly related to the citizen is the awareness of policymakers that can be fostered thanks to the UNCAN platform, because the European Commission is going to basically start an operational platform established in principle by 2023 that will bring together all the relevant players and information together based on existing efforts in Europe in order to combine research, patient health, and other relevant data for longitudinal cohorts with an unprecedented scale, because the key outcome is that new understanding gained from the analysis of this wealth of data can be applied to other diseases beyond chance. So this is, I think, a very important aspect I want to tell you, because these are advancements we expect to have in the coming years, and certainly an important lever also to push policymakers understanding these aspects.
Thank you very much, Professor Boccia. Professor Wang, I'm back to you. Can I ask you, what are the main obstacles you have faced in your country to encourage this kind of approach? And on the other side, what are the best levers you have used to implement personalized medicine in your country?
Yeah, I'm sorry, I just dropped the line because we have to use VPN to connect with your Zoom, you know. It is not very easy. Yeah, I always get off the line. So my opinion, I think the high cost of the detection using the next generation sequencing, as well as the cost of the drugs, may be the obstacles for Chinese patients to use the personalized medicine. Of course, we are taking a lot of steps to solve these problems. First, from the government level, we have a program. It called government. I just translated it. Centralized government procurement. Can you understand? You know, this is a program. When the drug come to the market, and it was with a very high cost, but you know, government will force them to reduce the price in 3 years. After 3 years, yes, and then get into the medical insurance system. So the price will be low. Will get lower and lower. So this is the government level strategy to reduce the price of the medicine. Also, you know, in China, we have a lot of generic medicine. The government, you know, they allow the generic medicine development in China. So this is another way to reduce the price of the medicine, personalized medicine. And for the detection method, I think clinical trial is a very good way, because I work in clinical trial center now, in National Cancer Center, Chinese Academy Medical Sciences of Cancer Hospital of Medical Sciences. So we have a lot of clinical trials that are going on. So the patients, they can choose to enter one of them. I think most of patients, they are available to get into the clinical trial system. So a lot of clinical trials, they provide free next generation sequencing detection for the patients. At least they can get the results if they have a positive, useful with the drugs, with targeted drugs now already in the market. So I think this is another way we can provide for the patients.
I understand that the price can be an important obstacle, and this is true in Europe as well. So I understand that you are encouraging to approach and to tackle this problem very seriously, to make this kind of therapeutic approach accessible to the highest number of patients, which is exactly the same challenge that we face. Professor, I just want to remind every participant that you can ask questions writing your question in the chat. Then when I have questions, I will ask the speaker. So please don't hesitate to ask questions if you have some. Feel free to do that anytime you wish. Professor Boccia, I'm back to you. If you have to mention a specific example of successful implementation, can you say something about this? There is a kind of best practice or a best example in Europe, and what kind of example it is?
Well, honestly, I have to partly repeat what has already been mentioned by Professor Wang. So the use of next generation sequencing is really spreading across Europe. The huge problem now to guide therapy, okay, in breast cancer, in colorectal cancer, and many other forms of cancer. The problem is reimbursement, okay, is to find a way to quickly make reimbursement for those tests were really effective, but also cost effective. I have to mention that as example, okay, in Italy, the next generation sequencing is still not within the essential level of care, but in 2021, additional funds have been provided from the government, like 20 million euro, and then other 5 million euro more recently. So divided across the regions, because we have not, unfortunately, a national health system, but a regional health system since quite a couple of decades. And this is the way in which government tackled quickly, I have to say, the reimbursement issue in order to give to all the patients the right to access a very effective drug that can change outcomes, like Professor Wang mentioned, the example of lung cancer. Again, at European level, there is in the mind of Scienzano that prepared this application within the U4Health call, just to extend the application of genetic profiling of patients and tumors in a way that cancer centers across Europe could take advantage of the national initiative and to better share the data, allowing to apply the same or similar diagnostic and therapeutic approach, and take up the molecular tumor profiling biomarkers that estimate cancer predisposition. Better counseling the family members. So also another thing I want to mention, again, quickly, the use of polygenic risk score. It's not a best example yet, because this falls in the prevention area, and it will be also addressed by a number of funding efforts from at European level. So we will understand in the coming years also the potential for the role of polygenic risk score to be used in the cancer setting more in the preventive side.
Professor Wang, firstly, you mentioned the problem of price, of cost. In Europe, essentially, we have two approaches to fund healthcare. One, countries like Italy, Sweden, Denmark have a national health service, which means a publicly funded via taxation with universal coverage approach. So essentially, citizens don't pay as patients, but they pay as taxpayers. So when they are sick, it's the system that pays for them. It's funded by essentially public funding. What about, and alternatively, in countries such as France, Germany, they have a social insurance. Social insurance means that they are reimbursed. What kind of system do you have in China in order to pay for patients? It's a mixed system, or what kind of funding mechanism do you have for?
Yeah, in China, where most patients, they are funded from the medical insurance from the government. A lot for people who have jobs from government, they will get the medical insurance from the government. Of course, now because the the financial development is very fast in China, so a lot of private medical insurance company is building up, and a lot of people, if they can choose to buy the the 商业化怎么说？ commercial insurance, medical insurance. Yeah. So they can buy both. yeah, from the government and both from the commercial medical insurance. So now it's getting more and more popular for patients who prepare for themselves for the major disease like cancer for those insurances. I think we have a lot of choices now, and people are, especially rich people, they are getting more methods to get covered by the insurance. So, but it still cannot cover all the patients, all the people, right? It only cover maybe 30 to 40. I mean, the commercial insurance only cover 30 to 40 people in China, but government insurance, they can cover 90% of patients. But you know, a lot of new drugs, the new personalized drugs, they cannot get into the list of medical insurance of the government. So it still remain a very high price. So that's why patients is worrying about the price. Mm-hmm. But now, you know, we have a lot of fund from government, like if you use these drugs for 6 months and it is still effective, and then you can get the fund from government, and the following drugs are all free from the patient for the patient. So this is another way from government who supported those patients using personalized medicine. So this is another way. And I think a lot of you know, personalized medicines from the international pharmacies, because it costs a lot, like 30 grand Chinese yuan per month. So those drugs, they will get fund from the government. Like patients, if you use it for 3 or 6 months, you still benefit from it. So the government will cover the rest of the cost from the drugs. So this is 3 ways I think the patients can get this problem solved.
Thank you very much. And I guess that the same problem of inequalities, I mean, in Europe, we have incredible inequalities, geographical inequalities between mostly West and East. We have socioeconomic inequalities. I guess that you are also thinking about how to reduce these inequalities. Is there any specific approach? I understand that the government is trying to bridge this gap, but what do you believe is the best possible even further approach?
You mean for the generic
yeah, in general, yes. Yeah.
In general, okay. You mean the quality, to how to control the quality of the generic drugs?
Yeah, in general, I mean, access to care, you know, so essentially what happens is that it's difficult, as you said, access to care, of course, to innovative drug even more. But in general, I guess for diagnostics and treatment would be the same. So what we are doing in Europe at the moment is to encourage member states to have comprehensive cancer center, you know, where you can concentrate and focus the excellence of care on a reasonable geographical distribution, you know, because just to give you an idea, there are still member states in Europe that do not have a single comprehensive cancer center. So you may imagine that in these countries, of course, the access to care is much more difficult. So we are encouraging, even with the kind of twinning model, to start this kind of approach. I don't know what is your policy about comprehensive cancer center. Are you encouraging the same approach in China as well?
You know, China is now making a lot of policies to cover more and more people in the medical insurance. So I think this is the main way to reduce the inequalities, right?
Yeah.
Inequalities in healthcare. This is I think this is from a government level to get a lot of people, more and more people to be covered by the medical insurance, no matter from the government or from the personalized or commercial insurance. That is the main way to reduce the inequalities in healthcare. yeah, well, another way is to get more and more novel drugs approved in China, which is very expensive, getting to the medical insurance of the government. So when they get into the system of medical insurance system, they will be, the price will be reduced a lot, like 70%, right? 70% to 90% of the price, so people can buy it.
Yeah, yeah.
People are available to the drugs. And another important way in China now is, I think this is a very good time for novel drug clinical trials. There's a lot of same pathway, same target, or same mechanism based drugs are in clinical trials. So we are, pushing forward the system, the clinical trial system, to all the patients, so they get more and more information from clinical trials, so they can choose to join the clinical trials and then get free treatment from the same mechanism-based novel drugs. So I think this is a very important way too.
Thank you. We have already one question from the audience, which I will ask shortly. But Professor Boccia, can I ask you a comment on this, on the inequalities? So what do you believe is the best possible approach to reduce inequalities?
Thank you, Professor Ricciardi. Well, partly you already mentioned the very important aspect of setting up the Comprehensive Cancer Center. There are either direct grant to member state authorities in order to create this Comprehensive Cancer Center, and to set up also within the Comprehensive Cancer Center such a multidisciplinary molecular tumor board. But I think also beyond the top-down approach, also a bottom-up approach that can help reducing inequalities is to make citizens and patients always more and more empowered. What does it mean? Make them having a good knowledge about the fact that this drug can make difference in terms of prognosis and the right for them to access this new therapy, but also not only patients, also citizens themselves, make the citizen understanding the revolutionary role that genomic had in cancer prevention and care. And in this sense, there are sparse initiatives across Europe to empower citizens in understanding the role of genomics in cancer. Some of them have been done in UK, beyond Europe, in the Genomic England program, and others have been done also in Spain, others also in Italy. So just for answering in a nutshell your question, I think also a bottom-up approach, empowering citizens, understanding the value of health data and understanding the value of genomic in cancer, can partly help in reducing in the long run inequalities in this context.
Thank you very much. I would start to ask the questions, and I still encourage the audience to ask questions on the chat, which I will ask to the speaker. I start from you, Professor Boccia. What would be, in your opinion, the first priority for regions when implementing personalized medicine? So we are talking now about priorities for implementation.
Among the first priorities, I think that we need a clear organizational path for patient and for citizen at risk. So citizen and patient have to be very much aware of what is expected, and regions have the role to foster clear communication and clear path within the care, either at local level and the hospital level. So I don't want to mention again the importance of for those countries like Italy that have a free access based on a taxation process. So first of all, possibility to reimburse, but again, organizational aspects, and also professionals, so oncologists, but not only, all the multidisciplinary aspects in place. So these are, from my view, the first three priorities for the regions.
Thank you. Back to you, Professor Wang. What do you think are the priorities for implementation of personalized medicine in your country?
You mean the better implement to promote the personalized medicine in China?
Exactly. Yeah, the priorities for implementation, yes. If you have to set priorities for the future, what would be your first or second point to start?
Mm-hmm. So to promote the personal, so first, I think from the hospital level, we should give more fund to the personalized medicine research, right? Give a lot of chances for the physician scientists that they can apply to use for the personalized medicine research. The second level, I think, is from the government level, they should set up more policies for the drug pharmacies, for the biotechs to develop new personalized drugs for patients. I think now we are doing good because the CDE from China are they are publicized a lot of documents to promote clinical trials in China, like the FDA. So we make a lot of advances those times for the personalized drugs development in China. What is mentioned to say is like this cell therapy and gene therapy, they are flourished in China now. So every doctors in our center, they know cell therapy, and we perform the cell therapy, and also as well as gene therapy in a lot of solid tumors, not only the hematology tumors, hematology malignancies. Yes, so this is a second way from the government level to promote the personalized drugs, because I think the cell therapy and the gene therapy will take the main role in the future in this area for personalized medicine, because it also target the gene alterations, it also target the immune systems. So I think this is a very good way to promote. So I think they should be priority in China. Yeah, and it is the right direction. It is now the right direction for the CDE and government level. They promote the clinical trials. So I think the other way to the other implements to promote the clinical trial, promote the personalized medicine is we should do a lot of genetic testing for the patients, not only the common cancers like non-small cell lung cancer, like melanoma, like a lot of cancer types that we already know well. Including the rare tumors, we should give them a lot of testing. Like in our center, we are, we focused on rare tumors. We build up a platform for rare tumor patients. We get them, they 已经上市要怎么说 listed drugs, and we also get them a lot of novel drugs with novel mechanisms in clinical trials, and we get them free sequencing about their genetics. So this should be another way to promote the personalized medicine in the future too. We care about not only common cancers, we care about the rare tumors. So, and this way will also promote the novel drugs getting to the market. So I think this will be in a large scale to promote the personalized medicine in the future in China. So I think that's my point.
Thank you very much. I'm going to ask a question about in the mission for cancer. We put a lot of emphasis on both preventions and personalized medicine. So we don't see them, of course, in an alternative. Can I ask your point of view on this? Start from Professor Boccia. I think that prevention and personalized medicine should be funded and should be pursued in the same time. We don't see them in contradiction. Can I have your comment, Professor Boccia, and then Professor Wong, please?
Yes, I fully agree with you. I mean, we know that prevention is definitely very much cost effective respect to curative care, but still at European level takes only around 3% of the health expenditure. Italy is one of the best, takes like 4%, but still it's few. I mean, this is in general. We know that the countries that use best resources also have a population in prevention, a population that is more healthy, so that as a disability time period of the life that is not that long, and as long as the disability time period of a individual is long, this consumes more resources. So in general, investing in prevention is definitely a good point, and this is especially true in cancer. And at the European level, there is now a project just funded within the family of ICPermed, which is the PROFET that I have the honor to coordinate, that aims to deliver in the 4 coming years a roadmap and a strategic research and innovation agenda in order to introduce evidence-based and economically sustainable, personalized, preventive approach, mostly based on genomics, but not only, also on the use of digital technologies into the healthcare. So I agree, of course, with your view, Professor Ricciardi, that prevention and personalized prevention can really foster innovation, save resources, and contribute to the sustainability of health system in general.
Thank you, Professor Boccia. Professor Wang, can I have your comment from your Chinese perspective?
Thank you. I think both aspects are very, very important. You know, in the prevention is a very important role of our hospital, of our cancer hospital play in China. So a lot of professors, they did a lot of things on prevention of cancers. So I think this is very important because prevention can hold the steps of the cancer happens, right? So I think this is very important, but I also think it is important too for the personalized medicine. For the invest in both areas, I think personalized medicine may cost more because that's what cancer happens. That's after what the cancer happens, right? We have to develop new drugs because there's a lot of cancer you cannot prevent, like the genetically cancer. You cannot prevent it happen. You can only, you know, treat the patients after the cancer happens. So I think most money should be put in personalized medicine. That's what I think. Yes.
So before we close the meeting with some final wrap up, Professor Boccia and Professor Wang, a final statement for you for the future of this project. This project is, I think, is the first project ever funded by both countries in order to collaborate. And I think it's important that there is a global collaboration for this. Can I have your final statements for the future of this project? Professor Boccia and then Professor Wang.
Thank you, Professor Ricciardi. So it was a long journey, okay? Because the project started 2 years ago, and 2 years ago we all were different. The pandemic was not there. We started with something in mind, and to some extent our also work and the way we work had changed, but still we were able to find, because we were able to join in a number of workshops, we were able to find common synergies in our view. And I think also today we were testimonial of these synergies. Also, we did find some things that are not, let's say, shared across the countries and that can be learned from each other. So for the future, what we aim to do is to deliver, as anticipated from the project, a common roadmap So we will meet in Rome, in fact, with all the experts that participated from China and from Europe to this activity of the past 2 years of this project. We will meet in Rome to deliver a first content of a roadmap where common views, common values will be communicated, validated, and shared. And I think this will constitute really a first ever effort towards finding a common approach in personalized medicine from two largest continents. So I'm very optimistic for the future and for the future collaboration with China.
Thank you, Professor Boccia. Professor Wang.
Yeah, just like Dr. Boccia's side, we have a lot of common in the development of personalized medicine and a lot of same values on developing the personalized medicine. So I think there will be a lot of aspects we can work together in the future in developing the personalized medicine. Just what we mentioned, a lot of things like clinical trials and basic scientific research. And maybe later we can use the doctors, we can exchange them from the different centers from Europe and China, so we can learn from each other. We have a conference with a professor from Denmark, a phase 1 center. He showed us how they did in Denmark. And we found a lot of common things in his slides. So we think there's a lot of things we can work together, and we can promote each other's career and our the strategy to conquer cancer and to develop more personalized medicines, and also as well as the strategies to make more people they can use personalized medicines from the medical insurance aspects or research fund from the government, how to make the government pay more fund for us to treat patients, to develop more personalized medicines. So I think there's a lot of things we can work together to make this happen, because this is very, very important. Thank you, both of you.
Thank you very much.
Nice
Professor Boccia,
talking to you.
there is a last question for you, which I think is important. Can you make some specific example of personalized prevention?
Well, in cancer, personalized prevention is there since a while in terms of genetic testing for hereditary form of cancer and cascade testing to the family members, like for breast cancer or for colorectal cancer, where actual intervention exists. I mean, in order to avoid the cancer onset on these patients, there is a preventive mastectomy, preventive ovariectomy. So these are really personalized approach to rare form of cancer, not that rare, and rare mutation, not that rare, let's say, because they have quite a high prevalence overall at the population level. Personalized prevention of cancer with the use of a more combined mutation like the polygenic risk score are still under scrutiny. So we do not have an answer yet. In fact, the European Commission will fund a number of initiatives in order to distinguish between the potential evidence-based and the sustainable approach in this context that make a difference in terms of prognosis and those not. So we have still to do a lot of work in the coming years, because in this sense, we still do not have an answer yet.
Thank you very much, Professor Boccia, Professor Wang. Has been a great discussion, and I think that we have to look to the future with optimistic approach, because this global collaboration, and in particular between Europe and China, I think it would be fruitful in all the discussion that we have had. So thank you very much, and I thanks, of course, you, and I thanks the audience. I thanks the World Federation of Public Health Association that has organized this webinar, which has been, from my point of view, very successful. So thank you very much indeed, and best wishes to us all. Thank you.